windlass bar. It just pulls that strap once it's in place. So that's one of the main reasons why you don't want to use the black strap tourniquet for training, because it kind of jacks up that internal strap and is going to make it not be quite as effective. But the way that it's preloaded and it's going to come out of the kit is this strap's going to be running through the first part of the buckle, the inside part of the buckle. And if you're placing this tourniquet over the arm, the upper extremity, you don't need to run the strap through the second part of the buckle. There's going to be enough Velcro attached that it's going to be secured, and it's not going to come undone as you're tightening it. When you're placing this tourniquet over a lower extremity, some people may have larger legs, larger thighs, and there's not going to be as much Velcro attached. So on a leg, you are going to want to pass this buckle or the strap through the second part of the back buckle, and then pull your slack out and secure in place. It's pre-rigged so that you can just open it up and slide the tourniquet up the extremity. Or you can remove the strap out of the buckle and then secure it. But it's best if you work with the strap facing outward, because it's easier to pull it and place. So remove all the slack out of the strap, bring it around on itself to capture all the Velcro, and then you're going to begin to tighten this windlass bar, and you're going to continue to tighten it until you cannot tighten it anymore, or until bleeding stops. Once that's happened, then you can secure the bar inside one of the buckles, and then place the Velcro closure over the buckle. I know I'm kind of blocking your ability to see what I'm doing. If I swing it around a little bit here, give the camera a better view of it, you come around to this closure bar and then tighten the windlass bar. You can place it on either side. And then something you can do on the arm, because there's so much strap left over. You don't want to get this hung up when you're moving the patient and blow out the tourniquet. So you can, although this isn't required, you can pass the rest of this strap through the closure bar there and then secure it in place. Now, if it gets caught on something hung up, this isn't going to blow out the tourniquet and remove it. So that's just something that you can do. And then just kind of pack this around, get it out of the way. You can do this over the clothing. Remember, this is a exsanguinating hemorrhage. We need to get this tourniquet on as quickly as possible. So just going over the clothing as high as you can and as tight as you can on the extremity. And then write the time on this white band here of when the tourniquet was applied. For applying the tourniquet to the leg, you can use the same technique. Something that you can do if you walk up to this patient and you can see that there's a significant hemorrhage in the leg and is bleeding out, you can come in and quickly you can drop a knee into the groin area over the femoral artery, and you can temporarily do a pressure point blocking that femur up against or basically penning it against the pelvis, and that'll help to slow the bleeding down until you can get the tourniquet on. When you're placing the tourniquet on the leg, same thing, you can either come up the leg or you can remove the strap out of the buckle and go all the way around. Bring the strap back through that first part of the buckle and then the second part. And when you do this, it's going to get kind of grabby. But you still want to remove all the slack out of that tourniquet and then bring it around. And so now you're covering a larger limb. You don't have as much strap left over. Once you've done that, then you can tighten this tourniquet down, lock it into place. If you do have any more strap, you can pass it through the buckle again, but again, that's not necessary or required, and then put it in place. Now we're going to reassess. Do we have bleeding controlled? or do we need to apply a second tourniquet? If we do need to apply a second tourniquet, then it's going to go directly below the first one on the extremity. Still high and tight. These tourniquets are about 1.5 inches in diameter, or their width. So now essentially you have a 3-inch wide tourniquet covering more surface area. And so this one would be placed just the same as the first one, removing all of the slack out of it, and then you're going to secure it in place. So now you have both tourniquets on. Now as we work our way down the March principles and we get to circulation, we can actually bandage up this wound on the extremity. Right now we're just trying to control the bleeding, stop that flow of blood. All right, now I'm going to talk about actually placing the Israeli bandage and the best way to do that. There's a couple different techniques and different ways to use it, and so we'll talk about that. So the Israeli bandage, once you've removed it from the packaging, this packaging could be used in a pinch as a chest seal. You just tear it open the rest of the way, tape it to the chest. It's a nice thick package, or you can toss it to the side. This bandage, you get it out of the outside packaging, and you got to remove it out of the clear packaging. And again, it's got a large pad that's attached to it. There's a sticker on the outside that says "Other side to wound." You can basically place that sticker over the main part of the wound. If you have an injury to the forearm, let's say, on this individual, you place the bandage over the wound and bring this end part around. Now we're going to wrap around the bandage. Obviously, in the real world, I would have gloves and eye protection on and everything, but I'm not going to do that right now because it's easier to see what I'm doing. Little disclaimer. So our first wrap, we're going to go around one side of this pressure bar, tighten it down. Second wrap, we're going to go around the other side of the pressure bar. We've now captured this bandage in place. Now we can bring the bandage around and pass it through this pressure bar, and then we're going to bring it back upon itself, and kind of a change of direction. Now this is putting more pressure down over the wound, and then we can continue to wrap over that. Another thing that you can do is you can put a twist in the bandage directly over that pressure bar. That'll add even more pressure. And then if this person is, say, walking wounded in an MCI or is ambulatory, something that you can do is just bring this bandage around and secure it to itself, and now the patient's been bandaged but now also has a sling. Or you can wrap it around the chest. But if you're just going to be using this bandage and wrapping it all the way around the extremity, continuing to really pull all that slack out on every wrap that you're doing. You can effectively make this thing a tourniquet if you pull it tight enough. And then at the very end, there's this closure bar that has 2 tabs, and they've got some teeth on them, so all you have to do is just pass that over the bandage, and that's going to secure in place. It's going to grab and secure in place. Doing a compression bandage with the normal ACE wrap and a 5x9 gauze pad. Basically is going to be the same, although it doesn't have the pressure bar or the closure strap. So there's just a few changes. You could either use the 5x9 or the bulky dressing, place it, and then you're going to have to really keep your progress with pressure, otherwise this thing's just going to unravel and shoot out. So your first couple wraps might not be real tight just because you're trying to get this in place, but really wrap on both sides of the bandage with your first couple of wraps, And then once you've got the bandage secure, then you can really pull that extra elastic out of this bandage and really start tightening it down for your compression. You can do that twist in the bandage, and that's going to help to put that downward pressure on. And then you can just continue. I cannot keep this door closed. You're going to continue to wrap this, pulling all that slack out as you go. And then when you get to the end, you can either just tie a knot in this and stuff it underneath one of those wraps, and that'll hold it in place. Or there's Velcro on this end to just secure it to itself on this bandage. And then it's in place. This is going to help. This ACE wrap will absorb some blood, but mainly it's on here as compression. You can get so much more compression out of these bandages than you can with just normal standard Kerlix or Coban. Another benefit of these is wrapping head injuries. Because of the the tightness of the bandage, is going to stay in place a lot better than the Kerlix that tends to sort of just cone off of the head, and you have to end up wrapping around the chin and holding it in place. These bandages are going to stay where you place them, so you can really dress the bandage as you do your wraps, because the tighter you pull, the more the bandage is going to want to bunch up, so you can just kind of dress it as you go and lay it flat. So that's kind of the big an overview on how to use these different bandages. So now we'll just go over a real rapid blood sweep, and then as we go and identify injuries, we'll treat those. So we'll just kind of make these bandages that are already placed out of sight, out of mind, and then we'll start doing our rapid blood sweep. I'm going to kind of just go through it systematically. Obviously, I'd have gloves on, and you may consider wearing 2 pairs of gloves in case you get the first one real bloody. On your first blood sweep, you can pull those off, and because we're really looking for blood, not just feeling for it. So, and then you have a fresh set. So with your blood sweep, we're going to do just a real rapid head to toe, and we're just looking for that massive bleeding. The March principles, the M stands for massive bleeding. So we're going to start at the head, and you're just going to really quick sweep over the head, going over the back of the head, through the hair, and then the back of the neck. Check your hands. If you don't have significant blood on your hands, you're going to continue to go. Normally on our assessment, we work our way from the head to the toe, doing the head first and then the chest, and then working our way down the legs, come back up and do the arms. With the rapid blood sweep, we're going to do this a little different. If this is a patient that you suspect there's penetrating trauma or significant bleeding, we're going to do the extremities before the chest. And the reason for that is we can quickly apply a tourniquet and control that bleeding. So we're going to do the extremities and then the chest. So we do our head, and then we're going to do one extremity. You basically want to encompass the arm or the extremity with your hand as best you can and slide your hands down so that you're covering the whole thing. So sweep along the arm, check your hand. Sweep along this arm, check your hands. They're clear. So now I'm going to do the legs. I'm going to sweep this leg. It's clear. Now I'm going to sweep this leg. We'll say I find a huge amount of blood. I see that there's an arterial bleed down here. It's pumping blood out. I can kneel down on that femoral artery to temporarily control that bleeding. I'm going to get my tourniquet out. Just for the ease of viewing, I'm going to run with the strap going inside, but again, you typically want to have the strap facing outward just because it makes it easier to secure. Bring the tourniquet up high and tight. We're doing the leg, so we're going to go through the second part of the buckle. We're going to remove all of the slack out of here, secure it to itself, and then I'm going to start to tighten the windlass strap or bar here, and I'm going to continue to go until I can't tighten it anymore. Secure it in place. Got a little tail here that we can tuck under there, keep it from blowing out, and then write our time. Now we've controlled this bleeding. We're not even going to look at the injury right now because we want to make sure that we have all bleeding controlled. We're going to come up, make sure we've got the neck and the inguinal area up kind of up in the major vessel area up here underneath the collarbones. And then we're gonna check the chest, running down the chest, also checking that axillary area underneath the armpits where a lot of injuries get missed. Check your hands, slide down over the abdomen. We're gonna roll our patient, and now we're gonna check the back, doing our blood sweep, looking for blood, and then the pelvis area. If when we do that, we find that this patient has a penetrating injury to the chest, you can place a gloved hand over that initially. That's going to help to seal that. And then we're going to want to remove our chest seal, get this out. Have a partner hopefully do this, or have your partner holding that seal. You want to remove this backing off the adhesive part of this bandage. This is the Asherman chest seal, vented seal. Place with the vent over the wound, and then just lay it in place. If there's a lot of blood there, you can use some gauze to just wipe that clean, just to try to get a better adherence to the skin. The other option is using a defib pad. This one says expired chest seal, just to help people know why there's a defib pad in there. And then just cut the cable off and draw an X over it. If we have exit wound, on the back, we may place the vented seal on the front and then roll the patient and place this defib pad on the exit wound on the back. Or you could do the defib pads. With these, since they're not vented, if you place it, you may have to burp it. We're going to have a video of how to do these techniques here in a little bit. So you've placed this chest seal. So I did my full blood sweep, placed the tourniquet. Obviously, if there's more responders on scene, you can be dealing with these injuries simultaneously if you need to. But I identified that injury there, and rather than wait and until we get to the respiration phase of March principles, if you do see a hole in the chest, obviously you can cover that up and control it. So we've done our massive bleeding. Now we're going to go on to the A of which is airway. So we're going to evaluate the airway. Is it adequate? Is it clear? Do I need to secure this airway somehow? We'll say that this patient does not have these injuries that you're seeing right now, and that the airway is clear and stable. So then we're going to go on to the R, which is respirations. Now we're going to evaluate the rate, quality, the depth of this patient's breathing. Is it adequate? Do we need to assist ventilations, put oxygen on this patient right now? Do we need to deal with this chest injury? We already did. Now we need to consider chest decompression. Remember, if we've decompressed one side of the chest and we are manually ventilating this patient, we need to decompress the other side of the chest, adequately have ventilation, since we're supporting ventilations, or if we intubate this person. Once we've dealt with these chest injuries, now we can go on to circulation, which is the C in the March principles. Now we're going to come down here and we're going to bandage this wound and any other wounds that we found, whether we're doing it with compression, dressing, or cling, or direct pressure, whatever we choose to do. We're also going to evaluate, is this tourniquet effective, or do we need to add one? And we'll have a video here in a little bit to segment to show doing the wound packing, but basically it's the inguinal areas and then the axillary areas. Too high on the extremity to control bleeding with a tourniquet, so we need to do it by other means. And then remember the chest and thoracic cavity is an open cavity, so we're not just going to blindly pack gauze into those wounds. And then we're going to go on to head and hypothermia. So we're going to identify this patient's mental status and their GCS. And then we're also going to help prevent any hypothermia. So keeping this patient covered, we're hot, we're working, but we may have just removed all of the clothing off of this person. So we want to make sure that we're preventing hypothermia when we, if it's indicated, and the earlier you start doing that, obviously the better. So We've done our rapid blood sweep, looked for any significant hemorrhage. Then we did airway, respirations, circulation, and then we did hypothermia and head. In the circulation part, if we identify that this patient has abdominal injury, we'll say that we see a abdominal evisceration. There's a couple different techniques for dealing with this, but a good little